Chronic pain is often a mitochondrial and inflammatory problem. Stay tuned to discover how photobiomodulation integrates with regenerative and rehabilitative care to shorten recovery windows and improve long term functional outcomes. Hi there, I'm Dr. Krista Burns, founder of the American Posture Institute and your co host for the Pain Summit. The purpose of the Pain Summit is to provide healthcare professionals with proven solutions to help your patients overcome chronic pain. I'm honored to welcome our next guest expert. Brooke McKeever is the founder of UltraRed Light in Newport Beach and is a leading educator for Light MD's Mark II photobiomodulation technology. She specializes in advanced clinical photobiomodulation applications for chronic pain, for inflammation, and tissue recovery, training practitioners nationwide through her Light Academy curriculum and real-world treatment protocols. Today, she'll be sharing with us photobiomodulation for chronic pain, a mitochondrial approach to faster recovery. Brooke, thank you so much for joining us as a speaker on the Pain Summit. Please take it away.
Hi, I'm Brooke McKeever. Thank you for having me. I'm talking today about photobiomodulation for chronic pain. We're going to approach it with mitochondria and how they can allow faster recovery for pain, injury, and post-op surgical care. Pain behaves like a systems problem. It's often not that it's just a local acute issue. When bioenergetic capacity is impaired, pain becomes a persistent signal that is difficult to turn off. So one of the things that it is about capacity. So when our capacity, I'm speaking about energetic capacity, how much energy your cells have to perform their optimal function. So when that becomes impaired, pain becomes persistent. This includes things like ATP availability, which is how our cells have that cellular energy to function. It is also about redox balance and where it can maintain inflammation as well as perfusion signaling. Oh, sorry. And another thing for chronic pain is the sensitization. We might have peripheral input like trapped nerves, tendinopathies, inflammation in the joint, central gain, where it's a signal that the brain is receiving on the pain side, and even autonomic tone. And that is basically where the body is in the protective state of fight or flight, like the peripheral nervous system is locked in this mode of perpetual pain and the signals, and it just can't get out of that loop. So what we're going to try to do is to put the body into that rest and relax stage so that one can help to expedite the pain recovery process. And our goal at UltraRed Light clinically is very straightforward. We aim to reduce this biological noise of inflammation and redox stress so that the system can actually downshift, reduce stress and overload on the entire body, and to restore the cellular capacity, modulating the very definition of photobiomodulation, and address those systems in the body as well as acute. We treat the pain site and the signaling network which sustains it. So we're going to talk about the mitochondrial and inflammatory loop. So mitochondria are pivotal in controlling pain phenotypes because they manage energy, redox signaling, and overall recovery capacity. They are the little batteries that need to be charged up, that are responsive for absorbing this light, particularly in cytochrome C oxidase, and that's the chromophore that absorbs this narrow action window of energy so that it may be processed in a photochemical way. When ATP levels are low, this indicates a deficit in energy capacity, which can lead to increased redox stress through reactive oxygen species. It releases nitric oxide at the same time, and then this stress is then compounded by inflammatory mediators, leading to the heightened pain sensitization, both peripherally and centrally. So that's a crucial clinical pattern to consider, is pain persisting beyond the healing of injured tissue when these signaling pathways remain amplified. This means that even if a patient or client appears structurally normal, their tests come back normal, their images come back normal, but they can still be experiencing this biological dysregulation, which often leads to confusion and frustration because we don't know how exactly to help them at that point. But by restoring the mitochondrial capacity, photobiomodulation, which I'll refer to from here probably as PBM, it leads to a reduction of inflammation, pain, and even flare-ups, followed by a decrease in overall pain. This is a significant insight for managing chronic pain more effectively because you're treating the whole person and the whole body rather than the original pain site. PBM serves as a powerful cellular intervention for this. It aligns with the body's natural processes, offering a form of metabolic and signaling rehabilitation. It's not foreign to us. We evolved around scattered light like the sun, but this light that we use is non-ionizing. So it does not have radiation. It's not harmful. And the biggest side effects that we have listed are dehydration. And that is very controllable. So when you're dealing with something like this, that's more on the natural and holistic side of things, we're not going to be interrupted by other chemical signals like pharmaceutical medications or bad side effects, which may inhibit the healing process. Instead, it uses red and near infrared light, and we use pulsed frequencies matched to the tissue in question. So meaning a nerve frequency is very different from a bone frequency, and very different from a muscle frequency. And so we can use those to target those specific areas, but also the systems in the body. The primary target here is the mitochondria, particularly the cytochrome C, which plays that crucial role in energy production and cellular respiration. This interaction can modulate nitric oxide, removing it from the cell, shifting respiration, leading to beneficial downstream effects. These effects include more ATP, which is what we need, improved redox signaling, better microcirculation, which all collectively help to reduce inflammation, which is going to be the root cause. Clinicians often notice a significant drop in pain variability, a reduction in flare-ups, a reduced guarding, making movement and loading more tolerable for their patients, which also enables them to proceed with rehabilitation programs like occupational therapy and physical therapy, which overall will get them stronger. As sensitivity decreases and tissues rebuild, pain reduction naturally follows. It's important to highlight that the discipline in clinical application is key. Dose and treatment area must be managed with responses tracked over time to adjust the therapy accordingly. This precision ensures that PBM delivers its full potential in patient care for the fastest and safest results. So let's discuss the positioning of clinical PBM like we do here at UltraRed Light versus consumer red light devices. So clinical PBM is all about safety, efficacy, and precision. And additionally, reliability. It's important to know that each time you're doing a session, that the client or patient is positioned in the right way where the pads are, in our case, they're comfortably wrapped on the body. In fact, I have a little piece here so we can see. So they're flexible and bendable. They're made out of medical grade silicone. So they, for example, if I have chronic neck pain, I want it directly on my neck. I don't want it to be on a wall or a panel where it's shining and my body, my 3 layers of skin will reflect and refract the light. It's very important to have that contact so that most of the light is going to be absorbed into the deep tissues. We don't just want it to scratch the surface. This isn't about just circulation or beauty. We're dealing with chronic pain here. We want to be able to get into the deep tissues, the bones, the nerves, the tendons and ligaments, and even the brain. And in order to do that, we have to have the pads conform to the body. So this means when we rely on verified output and dosimetry to ensure repeatable results, because clinical PBM needs to be about that. This means that every treatment is consistent thanks to controlled dosing and that consider the area of being treated, the time, the pulse frequency, and the total amount of fluids that is going into the body. We have physicians that are using our system, including pain management doctors, regenerative medicine physicians. We have PAs and RNs. We have physiotherapists and DPTs, dentists, neurologists, trauma surgeon, and even veterinarian. And also we have other people like myself. I'm a scientist, but we have regular people who are doing this and offering pain treatments to clients because they want to make a change in the world and help people. So it does not have to be, you do not have to be a doctor to operate this technology. It's something to integrate into every basically practice. Contrast this with consumer red light. Anybody can buy one. You can buy it at home, and that's no problem. I'm so glad that they are widely available so that clients and patients can now feel like they can take some of this care into their own hands for aftercare once they're done treating you. But variability here is a major concern. Irradiance and stability can vary widely, often leading to inconsistent dosing. For example, measurements are frequently taken not at the panel face, not at the skin distance, resulting in less accuracy. Treatments tend to be a lot shorter because the bulbs are brighter because of the lack of touching to the skin, of the skin contact. And that changes things. So getting the proper amount, proper dose is very difficult to do with those types of devices. However, protocols in clinical settings are built for repeatability and documentation, ensuring disciplined regulatory and labeling standards. Consumer devices, on the other hand, often suffer from user-driven compliance and positioning errors. And marketing claims can outpace clinical standards. The louder voices tend to be the ones trying to sell more product, and those are what we're exposed to. So in my clinic, I have my clients, and a lot of them will have face masks. We do beauty stuff here, but we focus on pain in our clinic and deeper health issues. And so some of them will have red light masks, and you'll hear them saying they tried to put their mask on at home in between, and it just didn't do enough. And that's totally fine because at least they're getting some sort of relief. So remember, if the dose is unknown or unstable, this is going to be the outcome. This is why clinical PBM is a critical choice for predictable and effective results so that we can have the predictable outcomes that we're looking for. What medical grade means in our clinic at UltraRed. So let's talk about the LightMD Mark II device. This is what we exclusively use. I won't go too far into this because I want to talk about what we are doing here for it. So in medical grade, this device is FDA 510K class 2 medical device approved. We've also been audited twice, and it's approved for its use in phototherapeutic red and near infrared applications, including topical heating and temporary relief of minor muscle and joint pain, stiffness, and to increase local circulation. Now that is our on-label use, and we do that and off-label use in our clinic here. But on-label, this device has been around since the early 2000s and has been tested widely in hospitals as well. And with this device, we have dual channel control, allowing us to address that systemic and local targets in a single session. So you can see it has 2 outputs there. And so that is you can treat the brain at the same time as the body, or you can relax the nervous system at the same time and do a local treatment. And we meticulously document each client's journey at UltraRed by recording their pain levels, their types of pain, their treated areas, the duration, and their response trends. We ensure that every treatment is as effective as possible. This documentation supports our commitment to a disciplined clinical workflow within our wellness clinic model. Finally, the clinician's mindset ensures that our clients receive the most effective and provide precise evidence-backed care. It also ensures that those we train to use the LightMD system will be able to reproduce the same results that we see in our clinic. And that's important because we need it to be consistent and aligned with the research that we have done. Let's dive into the logic behind our protocol, which integrates systemic and local targeting. First, it's crucial to understand why local-only treatments can underperform, particularly in chronic pain cases. Key drivers like central sensitization means the body's pain perception is heightened. It's like turning up the volume on a stereo. It just gets louder and louder. And that can be perceived differently and consistently. This, coupled with factors like autonomic tone and sleep disruptions, can significantly lower a patient's recovery capacity. In addition, there are persistent peripheral drivers, such as issues with joint capsules or nerve irritation, often require more than just localized intervention. Patients that have several underlying pain generators, even if one symptom is prominent, that may supersede the other. So our dual channel logic addresses both those systemic and the local needs for our clients or patients. Systemically, we focus on regulation by targeting areas like the spine and proximal neural hubs, like the spinal cord segments and the dorsal root ganglia, nerve roots in the brainstem, which are often linked to those autonomic functions. It's often that I'm treating the brainstem or the forehead and ears to tap into the vagus nerve at the same time as treating a client locally. In the locally, we concentrate on those specific tissues such as the joint capsules and the nerve courses. This comprehensive approach helps us tackle both the root of the pain and the systemic pain that it's creating more effectively. If you're missing the root of the pain, you're merely addressing the symptoms, and it becomes more like a Band-Aid. By balancing this systemic regulation with targeted treatment, with targeted local treatment, we can better manage chronic pain and improve overall recovery. So dose discipline is at the core of successful PBM therapy. Let's explore the concept of biphasic dose response. This is where the magic happens. Dose is the difference between results and failure, or commercial or commercial or generic red light therapy. Or clinical red light therapy. In PBM, more isn't always a good strategy. Dose is actually in that curve. That's because more is not necessarily always better. It depends on the irradiance, the fluence, the treatment area coverage, the duration and the total amount of energy that is entering the body, the pulsing delivery, and how often the patient or client is able to visit and what the results are. Depending on the results, it's like fine-tuning an instrument for our clients. Each parameter needs precise adjustment. Now, negative trial results that have happened in PBM, because now there's over 500,000 publications on this, and any negative ones seem to be tracing back to a mismatch of these parameters in the dosing and inadequate dosing. And often responds as well because we are, as humans, are completely different size than mice. A lot of the studies are on mice. And if you're covering a small little portion of the mice's lungs, that doesn't translate to a portion of a human lungs. Maybe 1/1,000,000th of the size of a diode, where it's 1 out of maybe 10 to 20 for a mouse that in question that we're studying. So the proportions are off, and often those get mistranslated into something being entirely effective when it can only affect just a small area. So that's important as well. So now we can explore how we apply our protocols to real-world chronic pain phenotypes. In our clinic, we see 3 types of phenotypes daily. For spine-dominant chronic pain, we focus on systemic targets like the spine and the proximal neural hubs, targeting areas like the joint capsule or tendon insertion. Our goal is to reduce pain and rebuild that load tolerance. We do that through the spine, but also through the brainstem. Typically, we see trend shifts here within 2 to 4 visits. And that is incredibly fast for patients. Oftentimes it's 1, but we just shift and give them a little hope enough to come back, but things really change around the 2nd to the 4th visit. Optimal results can happen in 10 to 12 sessions. That can all occur in 1 to 6 weeks. So we're talking about a dramatic reduction in pain and chronic pain in a short amount of time. Next, the neuropathic pain involves the systemic regulation and sleep support, while locally focusing on the nerve course and distal symptom regions. Here, the aim is to decrease burning and tingling and improve function. This generally requires a little bit more, usually around 5 to 20 visits. Lastly, the third one that we most often see are post-surgical recovery and pain. So for post-surgery that has stalled, we work to reduce inflammatory tone and support the recovery capacity systemically. We address the surgical field perimeter and mobility limiting tissues. Our goal is to soften that guarding, improve the range of motion tolerance, and strengthen those tissues while systemically reducing the inflammation and giving the mitochondria that energy so that it can process it into ATP and use it. Because overall, after surgery, our body needs to recover. It's your immune system, it's your circulation, it's everything that needs to recover in addition to the tissues that have been improved. We often see early wins in stiffness, sleep, and inflammation, with recovery progressing 2 to 4 weeks ahead of schedule. Each of these phenotypes showcases our customized approach aiming for sustainable pain management and enhanced quality of life. PBM is a force multiplier in chronic pain management. So anyone can integrate and add this to their clinic. You don't have to be a health practitioner. You can be an entrepreneur that loves to help people. It's designed to integrate into your existing care model without causing disruption. Staff members may operate the technology, and it is a set it and forget it, not needing to be attended during the sessions. So let's break this down into 3 key areas. First, we evaluate and strategize. This involves understanding the client and patient's pain, their capacity, and any contraindications they may have. This helps us in tailoring the exact protocol that we need for each client. Next, we look at the dosing. We focus on systemic and local effects with measured parameters, adjusting the dose based on the person's response. How they respond to the first session is going to give us a guideline of how long we think it's going to take. So I often don't give those estimates until a client has gone through the first session, so that way I can see how fast or slow that their body is responding. They may, water is a big function of this, stress load, sleep, and their environment, and all these things play a factor in their healing. This responsive approach helps us to optimize our outcomes. Finally, we consider rehab and loading with their PT or movement specialist. We don't do that at UltraRed. Here we support movement quality and strength and tissue tolerance by working with their physical therapist or recovery specialist so that we can aim to improve their full return to life goals. So PBM supports this by improving that tolerance to rehab and reducing pain so that they can advance in their recovery, making it more smooth and sustainable. So importantly, PBM is a flexible tool that can be layered with other treatments like manual therapy, injections, medications, surgery, and it supports that natural recovery post-procedures or injury itself. This adaptability increases patient adherence because the sessions are manageable and effective. Lastly, I say that PBM belongs in chronic pain care. It restores capacity so that your work in your clinic can shine. Next steps would be to visit my clinic and observe protocols in real patients and clients, or you can rent a LightMD system for clinical or home-based support, which we guide you on. And lastly, you can purchase LightMD Mark II equipment for your practice, and we train your team. Thank you so much for having me, Dr. Krista Burns. My last slide here is we have publications with our technology that we use in our office. So they're listed here on post-op TKA that was completed in a hospital. We also have COVID case studies that have been published. And then we have an ongoing one for depression. So very different and across the board. And then here are my sources as well. Thank you for having me.
Wonderful, Brooke. Thank you so much for sharing this excellent presentation with us. I'm going to go through a summary and then a couple of questions for you.
Absolutely.
All right, I'm going to go ahead and get started with the summary. So, today you shared with us fast recovery for pain and post op surgical care. So, chronic pain is a systems problem. Looking at the bioenergetic capacity, how it's impaired. The persistent pain signal then continues. If we look at capacity, it's associated with ATP availability, redox balance, and perfusion signaling. With sensitization, it's peripheral input, central gain, and autonomic tone. And then with the clinical goal, it's to reduce biological noise through inflammation and redox stress to the system so that it can downshift. And then restore cellular capacity and modulate the systems in the body, treat the pain, and allow the signaling network that sustains it. So the mitochondrial and inflammatory loop, looking at managing energy and redox signaling. The clinical pattern, so ATP deficit or low capacity associated with redox stress, and then reactive oxygen species signaling, then inflammatory mediators, and then sensitization, peripheral and central. So pain persists past the point of tissue healing due to biological dysregulation. We need to restore mitochondrial function to reduce flare-ups and decrease chronic pain. So treat the whole person, not just the original site of pain. With photobiomodulation, it's powerful for metabolic and signaling rehab. It's non ionizing. Light input is red and near infrared, and the dose matched to the tissue. And this leads to mitochondrial target, which is the cytochrome C oxidase, nitric oxide modulation, and respiration shift. And then we have downstream effects. So more ATP, better redox signaling, inflammation reduction, and increased microcirculation. Clinicians see less guarding and less pain for their patients. Dose and treatment is going to be important, so precision allows fastest and safest results. So looking at clinical photobiomodulation, we have verified output at working distance, dose tracked, so the area, the time, the pulse, and frequency, large uniform coverage for systemic work, protocols built for repeatability and documentation, regulatory and labeling discipline, and needs to get to the deep tissue, so place the pads directly at the site. Paid treatment that can be implemented into all clinics. And this is going to be different than consumer red light. So there's more variability and inconsistent dosing, which can lead to less accuracy and varied results. So medical grade means the FDA phototherapeutic red and infrared dual channel control for systemic and local targeting, document pain levels, types of pain in treated areas, and delivers photobiomodulation as a disciplined clinical workflow inside a wellness clinic model. So local only treatment underperforms, especially in chronic pain patients. So central sensitization is turned up, plus we have increased autonomic tone and sleep disruption. So patients have multiple pain generators. With the dual channel logic, it's looking at systemic regulation and local tissue. So systemic things like the spinal, the spine, peripheral nervous system, central nervous system, and locally joint capsules, peripheral nerve cores, and tendon insertions. So dose discipline for successful photobiomodulation therapy looks at wavelength intent, irradiance at working distance, treatment area coverage, duration and total irradiance, pulsing delivery, and visit frequency and response. So you shared with us 3 different chronic pain phenotypes, which would be common to see in clinical practice. So spine dominant chronic pain, number 1. So systemically looking at the spine and proximal neural hubs. Locally, the joint capsules or tendon insertion. And then the goal ultimately is to reduce pain variability and build tolerance. And you usually see that in about 2 to 4 visits and then optimized fully at about 10 to 12 sessions. And with neuropathic pain, systemically regulation targets sleep support. So locally, following the nerve course and distal symptom region. I'm looking for reduced burning and tingling as our goal and about 10 to 20 visits. And then post-surgical pain systemically to reduce inflammation, locally for surgical recovery capacity. And the goal is to soften guarding, improve range of motion, and strengthen the tissues. So 2 to 4 weeks ahead of scheduling for healing post-surgical. Photobiomodulation is a force multiplier for disrupting chronic pain. So we can evaluate and strategize, understand the pain phenotype if they have sensitization in their capacity, and then look at dosing, so systemic and local effects, adjust dose based upon their response, and then rehab and loading, so improving movement quality, strength and tissue tolerance, and then return to life goals. So photobiomodulation reduces pain, making recovery more sustainable, and it's a natural recovery process. And it also helps patients have increased adherence. So ultimately, it belongs in all chronic pain care. Thank you for sharing this excellent presentation with us. A couple of questions for you. What would you say to the patient or the client who wants to try photobiomodulation and they don't feel anything during the therapy itself? How do you describe to them that it's working and what to expect during the treatment?
Mostly our clients will feel something right away. I think it's because of the way that the pads are basically conforming to the body, is that they always will get warm, and it's not the pads themselves because it's not a surface level heating pad. This heat is coming from the increase in energy and increase in circulation inside the body. So, what our clients often describe it as a warm hug coming from within, a deep relief. So, it's hard to say if they don't feel it. Some people, if they have severe chronic pain, like somebody comes in a 10 out of 10 pain, um, I I don't expect them to get off the table feeling uh, a ton of relief. However, it has happened many times where they come in and they're already down to a 6 or an 8 or a 4 in pain, which I believe is the body understanding using that energy to help those tissues and muscles relax that may be guarding those areas of pain.
Mhm.
Now, if they don't feel it, how I explain it to them is that it's working. We are biologically human, and light, it just by the science and the nature of it, is it works. And what I let them know to expect in about 6 to 8 hours for it to really kick in, and then the morning after to check in with me. And I often will check in with my clients as well over the next 2 days to see how they're feeling, because that morning after is when we kind of see the peak, and that energy in them will last for 48 hours. So if they don't feel something right away, or if they just have the thermal benefits, I tell them to look forward to how they sleep for the next 2 nights and how they feel those next 2 mornings.
Excellent. Yeah, thank you for that. We'd love to always anticipate the patient's needs, questions, and then let them know what to expect with treatments.
Absolutely.
And then my next question for you is, when integrating photobiomodulation into a full pain rehab clinic, so let's say we're doing manual therapy, other modalities, maybe some exercise therapy, all in office, in addition to at-home care, would you say that photobiomodulation needs to be done before manual therapy, after manual therapy, during other modalities? What's the best way of incorporating it for optimized effects?
We like it before other manual therapies. I think that's because it can increase that local blood flow, but also to relax the guarded muscles and tissues, and anything with stiffness can also be more manageable. And so doing that before, now there's no problem to do it afterwards. If there was, for example, somebody did ART or this manual therapy that was a little painful, doing light at the end of it will help that recover that pain and to recover those tissues and adhesions better as well. So there is no really strict rule, but our patients tend to like it beforehand, as well as the therapists.
Wonderful. Thank you so much. And as we
Absolutely.
wrap up another great session today in the Pain Summit, I'd like to acknowledge Brooke for her excellent work in pain management with photobiomodulation. I'd also like to acknowledge you, the practitioner who's learning up-to-date clinical solutions to help your patients overcome chronic pain. I'm Dr. Krista, your co-host of the Pain Summit. Click below for on-demand summit access, and don't miss the game-changing integrated pain specialist certification held exclusively for healthcare professionals. Stay tuned, and we'll see you on the next Pain Masterclass of the Pain Summit.